So we're going to talk about two controversial things. We just listen and listen and listen a lot to cataract and more cataract for angle closure, and here I come with a completely different approach, which is tuberculectomy, which I think is the answer. The World Health Organization has estimated that 53 million people with glaucoma will be blind due to primary angle closure glaucoma by 2020, and 86% of people with primary angle closure glaucoma live in Asia, with approximately 40% of them living in China and 23.9% of them living in India. Many people might not believe the statistics, but the situation is serious. 3 million people are blind from primary angle closure glaucoma, with half of them being blind from acute primary angle closure glaucoma. So we've got to look at primary angle closure glaucoma far more seriously than we look at open angle. Patients with primary angle closure glaucoma commonly present with one of the three possible scenarios, like everyone has described: an acute angle closure, a narrow angle at risk of acute closure with normal intraocular pressure, or a creeping angle closure with or without elevated intraocular pressure. Patients may present with what appears to be a chronic open angle glaucoma, but angle closure is subsequently discovered on gonioscopy. And I'm not going to talk any more on gonioscopy because the previous speakers have done really good justice on the need for doing gonioscopy in every patient who has a suspect glaucoma. Now this is what cataractous lenses in angle closure look like. The previous speaker, Anuradha, has actually spoken pretty well on what happens when you have a cataractous lens. You could have a cataractous lens with a very narrow angle, as is seen here, or you could have a cataractous lens with a narrow angle only peripherally and a good deep anterior chamber. But of course, you've got to look for telltale signs. And like Usha Yadav already mentioned earlier on, you have to look at the pupillary rub, you have to look at the iris atrophy. All of this tells you that this patient has had previous attacks of acute angle closure or angle closure which have gone unnoticed. And there are, like here again, you will see this iris atrophy. When you look at this, you know that this patient has had previous attacks of angle closure, but they have just gone unnoticed. Now, if you look at the ASOCT, you've seen many pictures on the ASOCT which have shown you an angle closure. There are no symptoms associated with creeping angle closure. However, the signs could include a normal or an elevated intraocular pressure, peripheral anterior synechiae in portions of the angle, possible optic disc damage, and possible glaucomatous visual field defects. We know, all of us know what is basically the mechanism of closure, because we know that the block actually starts over here, pushes the iris anteriorly, the entrance to the drain is then blocked, and that is how you finally get a raised intraocular pressure. The presence of a cataractous lens worsens the situation as the lens is thicker and hence occupies a larger space, decreasing the anterior chamber further. Also, the cataractous lens probably worsens the visual potential. Is angle closure a surgical disease? In my opinion, the answer to this question is yes. Surgical options for angle closure glaucoma are different than those for open angle glaucoma and depend upon such factors as the extent of IOP control with medications and the presence of coexisting cataract. Our choice of surgical intervention needs to take all these factors into account. You could have, like the case that Anuradha just described, yes, this is really a common scenario where you see a really, really cloudy cornea. You could have an anterior chamber depth which actually looks just as bad as this. You could look at the gonio and you can see that the angle is completely closed. And then you could also see peripheral anterior synechiae as are seen in this gonioscopic view. The treatment guidelines for angle closure glaucoma are derived through consensus by glaucoma experts based on the best available evidence. The World Glaucoma Association consensus has laid down these guidelines which address the goals of managing a patient with primary angle closure glaucoma. Firstly, to reverse or prevent the angle closure process, to control the intraocular pressure, and to prevent damage to the optic nerve. Iridectomy is indicated in all eyes with primary angle closure glaucoma. The main objective of surgical treatment in angle closure is to quickly decrease the intraocular pressure and therefore reduce the risk of further glaucomatous optic nerve damage. Surgical treatment also helps to ensure that progressive angle closure does not occur and that the risk of acute angle closure is therefore abolished. The surgical options are diverse and they include laser surgery, filtering surgery like tuberculectomy, lens extraction, combined lens extraction and filtering surgery, angle widening procedures such as goniosynostosis, lens extraction combined with goniosynostosis, or a combination of procedures. I, however, for one, want to think that trabeculectomy alone is what we can actually practice. In clinical practice, what we often see is the presence of peripheral anterior synechiae, which leads to chronic angle closure glaucoma, and reducing the intraocular pressure in these patients is a must. But you realize that more often than not, a trabeculectomy has to be resorted to in order to reach the target intraocular pressure. There is no evidence to prove anything else works as well. These are the peripheral anterior synechiae that you see. Going by the WGA consensus again, ascertaining the mechanism of angle closure is essential for management, and it should be used in conjunction with the classification of the stage of the disease. Further refinement of these systems, such as the inclusion of symptoms as a defining feature of angle closure, should also be made on the basis of peer-reviewed evidence. For instance, if you look at this, you see there is an anterior chamber jam. However, the jam is only at the periphery. It's not so much at the center. You look at the angle anterior segment OCT, which shows your pupillary block. This is what a phacomorphic glaucoma would look like. Now, laser peripheral iridotomy has been recommended in all cases of angle closure glaucoma. Laser peripheral iridotomy can be performed very easily on an outpatient basis, and patients can then be monitored for response to treatment. And Dr. Mayuri has already dealt in detail with laser peripheral iridotomy. This will allow time to undertake elective surgery in those with uncontrolled pressures and those with advanced disease or coexisting cataracts. LPI also serves as a prophylaxis against an acute angle closure. Trabeculectomy needs to be performed to lower intraocular pressure in eyes with primary angle closure or with primary angle closure glaucoma insufficiently responsive to laser or medical therapy. There is insufficient evidence for deciding which cases with primary angle closure glaucoma should undergo cataract surgery alone as of today. There is lack of evidence for recommending lens extraction alone in eyes with more advanced primary angle closure glaucoma. Published studies to date have been non-randomized with very small sample sizes and a very short follow-up. There is very limited evidence about the effectiveness of goniosynostosis in the management of PSEG. When there is associated glaucomatous optic neuropathy, cataract extraction with a posterior intraocular lens can be associated with a significant rise in the intraocular pressure in the early post-op period in patients with pre-existing glaucoma, which Anuradha has already dealt with. This can be because of a whole lot of reasons. It is possible that up to half of the patients may have an intraocular pressure of 25 millimeters or more, and the greatest asset in the care of these patients is to expect this rise and to monitor the intraocular pressure frequently and aggressively. It is important for the physician and the patient to also be aware that during the first 2 to 4 months after cataract surgery, many patients with glaucoma will have intraocular pressures above their preoperative baseline. When glaucoma is uncontrolled despite the use of maximum medical therapy, then there is a problem, and the surgery of choice will what is the surgery of choice that will control the intraocular pressure best? And this is trabeculectomy performed alone. This is the last slide. Only when you have a really visually significant cataract that the decision becomes more complicated. Sometimes it is better to just do a trabeculectomy. Just doing the trabeculectomy might improve the patient's vision for a time being, and then you can go on to do cataract surgery. Evidence-based medicine tells us that there is a need to lower intraocular pressure. Further, this will prevent further progression of both angle closure and disc changes. Trabeculectomy, therefore, is the answer, and there is, as of today, not enough evidence for cataract extraction alone or combined surgery either. Thank you. This really controversial topic again, because I'm not going to talk about trabeculectomy. So my talks are separated, so anyways, let's deal with this. This talk says phacomorphic glaucoma and acute angle closure. Is there something different in which we look at both these complexes? Because I have no financial disclosure. Phacomorphic glaucoma is a secondary angle closure glaucoma caused due to an increase in lens thickness, characterized by a sudden rise in intraocular pressure, which can lead to an irreversible loss in vision due to a compromised optic nerve head. So let's not get this mixed up. When we are talking about phacomorphic glaucoma, we know that there is an optic nerve head involvement. We know that there is a sudden rise in intraocular pressure. It's not just that there is a big lens sitting behind and therefore maybe it will give rise to phacomorphic glaucoma. When there is phacomorphic glaucoma, there is a rise in intraocular pressure. This increased lens thickness can be due to an advanced cataract, to a rapidly forming intumescent cataract, to a traumatic cataract leading to a pupillary block and an angle closure. The primary mechanism is a thickened and anteriorly displaced lens which may be associated with weak lax zonules, sometimes compounded by pseudoexfoliation. In India, it is generally seen in senile cataracts, though sometimes a traumatic cataract and a rapidly intumescent cataract are responsible. Rapid treatment in these cases is a must to avoid irreversible blindness, as synechial closure can happen, leading to a persistently raised intraocular pressure even after cataract extraction. The principles of treatment are quick reduction in intraocular pressure with medical management, which is a must. In addition, you have to use steroids to reduce the associated inflammation. You must use hyperosmotic agents to clear the corneal edema because there is plenty of corneal edema. And if treated within 48 hours of the attack, the visual recovery has been shown to be good. The longer the period of raised intraocular pressure, the more is the optic disc pallor, and lesser the chances of visual recovery even after the cataract extraction. A gonioscopy, even in these cases, must be done, and the presence, if of any synechiae are found, then you have to think of doing a combined surgery because that is mandatory. Now, if you look here, you can see that this is the anterior segment. This is a UBM of the picture where you see there's swollen lens, big, huge swollen lens, and there's complete corneal iris contact taking place peripherally. So it's a bad situation. Now, what is the role of YAG-PI? It has been stated to have a good role in relieving the pupillary block. However, in most cases, the patients reach an ophthalmologist after peripheral anterior synechiae have already formed and the angle closure is more structural than functional. It does help in lowering the intraocular pressure as an alternative to medical treatment in the early stages, not once, we've gone a long way. And we all know how the LPI works. Well, there are a lot of problems that I encountered with phacomorphic glaucoma. First and foremost, you have corneal edema with decreased visibility. You have a compromised cornea because of the decreased endothelial count. You have a lot of inflammation in the anterior chamber. There's no visibility of the fundus due to a mature cataract. There's a very, very little anterior chamber depth. Hence, there's very little space for maneuvering. And there's a lot of positive lenticular pressure which increases the risk of extension of your rhexis. There are more problems. You could have weak zonules. You will have recurrent iris prolapse. You might have a very small pupil. There is always the risk of expulsive hemorrhage. There's a hard cataract to deal with. There's a lot of positive vitreous pressure. There are increased chances of a PC tear. There could be a persistent intraocular pressure rise. There could be an increased risk of post-op fibrinoid reaction and always the poor visual outcome due to irreversible optic nerve head damage. So what are the special features? The intraocular pressure in all patients must be lowered as much as possible preoperatively by whatever means you can. A B scan preoperatively to rule out posterior segment pathology is again a must because you can't really see the posterior segment because of that cataract. The inflammation must be controlled, and it is always good to do an ocular decompression if you find that the pressure is too high and come what may, you are not able to get down the pressure, because otherwise you will have a lot of positive vitreous pressure coming forth. So there are times when you might actually have to go in and do a vitrectomy, a 3-chord vitrectomy. It's always good to use a dye to stain the capsule prior to the rhexis because then you can see what is happening to the rhexis, because the rhexis quite often just pushes off to the periphery. You just make a nick and you see the rhexis has gone right round to the periphery. And AC deepening with liberal use of viscoelastics helps tremendously. You can use a viscoadaptive agent like Viscoat because that will also help protect the corneal endothelium. In case of an intumescent cataract, you can make a small nick in the capsule, aspirate out all of the fluid that you can, cortical fluid, to decompress the lens before making the rhexis, and even that works wonders. In case of small pupils, you can use iris hooks after you have adequately deepened the chamber. Another thing that you can do is, you must also do a very clean cortical washout to prevent a post-op fibrinoid reaction. Few other tips that I'd like to tell you that I have found very useful clinically is the use of cold balanced salt solution, because that helps to prevent endothelial damage and it reduces post-op inflammation quite a lot. Endocapsular rings must be always kept handy because you never know when you will need them, because there could be zonular dehiscence or weak zonules. Phaco must always be done in the bag with low parameters. You must have a low power and you must have a low flow rate. Only you keep the bottle height high. And a PC IOL in the bag gives you the best results. If a trabeculectomy needs to be done, it is best done at the same sitting. And whenever you have the presence of a peripheral anterior syndicate, raised intraocular pressure more than 3 days, then that is the indication for a trabeculectomy to be done. Trabeculectomy with MMC can be done either at the same site, two site. You can use either a phonics based or a limbal based flap, whatever you are convenient with. Post-op care is again very, very important. Meticulous post-op care can improve the visual results in phacomorphic glaucoma. You have to use potent steroids locally. Very frequent application, can be as frequent as half to 1 hourly to start with. You must also give a good antibiotic cover. Sometimes you might have to resort to systemic steroids, and you have to watch for the intraocular pressure post-operatively and control it medically. You have to, of course, look at the bleb post-operatively, like you shepherd all blebs in glaucoma. And if you have had to, do other procedures, then you must do an adequate refractive correction. If a vitrectomy has been done, then it's also good always to go back and do a detailed disc evaluation and a peripheral retinal evaluation to make sure that nothing has gone wrong. And it is always advisable to do a prophylactic surgery on the other eye if there is a lenticular change in case of the other eye. But there are, in spite of all of that, poor results, because there could be optic atrophy, there could be uveitis, corneal edema may not have resolved, you could have vitreous hemorrhages, retinal hemorrhages, PCO, retinal detachment. What is different in acute angle closure? Immediately, medical therapy in acute angle closure consists of commencing the intraocular pressure lowering medications as soon as possible. Once the intraocular pressure is sufficiently reduced to allow reperfusion of the iris, then you can start using pilocarpine, which will induce meiosis in an attempt to widen the anterior chamber angles and re-establish aqueous inflow. Now if you look at this, here you can see that the angles are completely closed. After having reduced the intraocular pressure, we started using pilocarpine. So now you can see that I have relatively myosed pupils and my angle has opened out. In addition, oral acetazolamide 5 to 10 milligrams per kilogram or hyperosmotic agents like mannitol, glycerol, whatever you want to use, can be used to lower the intraocular pressure. Once the corneal edema is resolved, a laser peripheral iridotomy can be done. Topical steroids may help to reduce the intraocular inflammation, while analgesics and antiemetics might help make the patient more comfortable until the LPI is done. I won't spend time talking on the LPI because we've spent lots of time talking on the LPI before. But there's another mechanism known as laser iridoplasty. When mechanisms other than pupillary block exist, laser peripheral iridotomy may be insufficient in opening the anterior chamber. Residual iridotrabecular contact after successful laser peripheral iridotomy is attributed to smaller anterior chamber dimensions and thick iridis, and in these cases you can do a laser iridoplasty. This is what the iridoplasty looks like. You'll see all these peripheral laser marks. And by applying surface photocoagulation burns in the iris, tissue contraction results in pulling the peripheral iris away from the trabecular meshwork, thereby opens the anterior chamber angle. 42 to 72% of cases presenting with acute primary angle closure can be satisfactorily treated with laser iridotomy alone, and 60 to 75% of such patients recover without any optic disc or visual field damage if the intraocular pressure is promptly and adequately controlled. Early lens extraction has been advocated where there is a significant cataract impairing vision. In conclusion, phacomorphic glaucoma is a special entity. It needs to be looked at differently. If all the necessary precautions are taken, we can expect to get good results. A word of caution, phacomorphic glaucoma can lead to a medico-legal problem if adequate consent has not been taken prior to surgery. Due to various reasons listed above, the chances of poor visual recovery can be a bone of contention. Thank you very much.
We'll move on to Dr. Ramanjeet expresses her apologies. She could not come due to certain reasons. But her topic, in short, I will just cover up. And her slides are there. They seem to be having some problems in loading her slides. I'll go on to that later on. We'll move on to when and how to do a phacotrabeculectomy. So much has been said about when, what should be done, so I will not go into this, and we are lacking time. But we do need to remember that the presence of a visually disabling cataract needs attention. Also, 50% of patients within 1 year of glaucoma surgery do develop cataract, and that needs to be looked into. And for a patient, all the vision is a faculty which they would not like to lose with the procedure. Also, whenever in a functioning trabeculectomy a cataract surgery is done at a later date, there is a chance that it may fail. Also, it has been found when only cataract is tackled, the IOP reduction may be insufficient to prevent further visual field loss and glaucomatous damage. It is agreed that doing phacoemulsification alone opens the angle and deepens the AC as compared to a phacotrabeculectomy. And also, if we compare the phacotrab with trabeculectomy, in trabeculectomy group, we do find that we need additional surgical interventions, especially in the form of a cataract later on. So, why don't we do the two things combined? Also, it has been seen that as compared to IOP reduction in a POAG patient, in PACG patients, the amount of decrease in IOP is much more after a phacotrab. So, in a sense, when we are doing a phacotrabeculectomy for closure which is more than 180 degree of circumference, the choice of surgery is determined by the visual acuity and closure circumference, cataract, medication requirements, and optic nerve damage. The phacotrab and PCIOL decreases the IOP effectively and improves the vision. And the long-term IOP is lowered much better by this procedure. There are many variables when we are doing this. We need to remember what is the type of glaucoma that we are dealing with. Was there an angle closure attack or not? What has been the duration since the attack? Because if we would perform this procedure soon after an angle closure attack, we do expect a lot of inflammation. Was the patient on any pre-op medications, and did it include a steroid? Because that would decrease the inflammation. Was he on any anti-glaucoma medication? What was there? How many of them were there? And whether the patient was sticking to it. The definition of success in different reports which are there in literature is also different. The amount of IOP may be 18 or 21, and the success may be remarked as with and without medications. Again, the post-operative management may give out a different outcome. The use of steroids especially ensures that we have a better outcome. When we are performing the procedure, whether it is a two-site or a single-site, whether the flap is fornix-based or limbal-based, whether mitomycin C is used or not, and in what strength and for how long, whether the scleral flap which was made is triangular or rectangular, the scleral flap sutures, whether they were releasable or non-releasable, and what were the number of these sutures? Was there a difficulty in pre-op dilatation? If there was, how was it improved? With hooks, sphincterotomy, or intracameral adrenaline? All these can affect the outcome. Whether we did put a suture in the phaco section, and how was the conjunctival suturing done? We need to have an adequate exposure, and we can do it either by these two methods. We take this case of a patient who came to us with a 41 millimeters of mercury, poor vision. He had undergone an LPI which was non-patent. We controlled the pressure medically and then went in for the combined phacotrab. In this case, we did a two-side phacotrab. The choice of the incision can be either superior and temporal. the temporal being for the cataract, or it could be, as it was in CIGTS, they did most of their trabs in the supranasal quadrant, with the cataract being done in the supratemporal quadrant. They need to be a little away so that neither your side port nor your crosses over with the incision that you are making for the glaucoma. Of course, the steps of meticulous phaco cannot be overemphasized. It has been emphasized by the previous the speakers. And we need to maintain the anterior chamber, whether we do it with viscoelastics or ensuring and giving pre-op mannitol needs to be seen. Each step needs to be taken one by one and done very carefully. Ensure that there is good removal of the cortex, and because if you leave it behind, and sometimes you may come across that there is zonular dehiscence, as in this case, but not to bother. You can just put in a CTR and continue without a hitch. And the placement of a single piece acrylic lens helps because we can manipulate that easily. The iridectomy is done after removing the trabecular meshwork, and before this we also try to constrict the pupil with intracameral pilocarpine, which may not happen if we had used some manipulations to dilate the pupil. At the end of the surgery, we have to ensure that the Siegel's is negative and it's a good suture. And it's a tight wound. The pressures are wonderfully decreased, and the patient, as in this case, gains a very, very good vision, 6/6. The site of the trab can be varied, and the two-side trab has the advantage that it has less manipulation through each of these incisions. Some say that it causes more endothelial loss. It does take a little more time, but there is a better surgical access. And in my opinion, I prefer to do this rather than do a single side. But these are post-operative pictures. I don't know how my other faculty would like, or other people would like to say, but I found that many of these patients end up with a capsular phimosis. Whether it is because we did not, the amount of polishing that we do is almost similar, but somehow they seem to have more capsular phimosis. Now, when we are doing the single side, in this case, we also use the mitomycin C. We need to remember that we have to perform both the surgeries together. When we make the scleral flap both in the single side and two side, without entering the anterior chamber, because this allows you to be in a good plane. If you make this after you have entered the anterior chamber, the kind of fold that you have is not so good. The incision which should be made should always be triplanar in these, because then it is less prone to leakage. Here, as the previous speakers had said, there is a little bit of corneal edema, and where we tackle the lens, now you can see some of the times it does get the flap, the triangular flap is actually getting a little more molded while you are doing the phaco, and you may miss it. So this can eventually alter the success of your trabeculectomy, even if on table it was very fine. Now, if we do a good bimanual aspiration, that should always be done with the polishing of the anterior capsule, and after this we insert the intraocular lens. Without waiting to finish the thing, the one side has more manipulation, as I said, and also causes more astigmatism. And in some studies have reported that there is more chances of blood failure. This is also this is interesting, because here it's the iris which had gone and blocked the trabeculectomy side. These are different patients who had undergone a phaco trab and had a good outcome. Now, the limbal based and versus conjunctival based, the phonics based, the limbal based, it needs more of more dissection, and the ring of steel may sometimes form, which may restrict the flow of aqueous backwards. The phonics based is easier to make, better visualization, but these are more prone to leaking. So we should be very careful at the end of surgery that there should be no leak. The suturing is also is easy. They are trying to do more and more meticulous suture by taking purse string sutures, and we're having a little wedge of the conjunctival over the cornea so as to prevent any leakage. Now, in the limbal based, they tend to fail more often, though this is being compared in trabeculectomies, not in phacotrabs, because of the presence of the steel ring. Then the PCO has been found to be more often in patients who have a limbal based conjunctival flap, and thus requiring more intervention in the form of capsulotomy. And the scleral flap, I will not go into this, but the suturing can affect the thing because if we put two sutures on the side, this allows that the flow of aqueous is directed posteriorly. This would prevent a cystic bleb from forming and a more diffuse bleb to be formed. And for this, we need to have be meticulous about our conjunctival dissection, and the way we remove the trabecular meshwork could either be with a punch or with a Vanas. And I'm rushing through because we have less time. The sutures which we put could be releasable or non-releasable, and it should be a combination of the two. The two site has been found to be have comparable, both of them have comparable IOP control and similar amount of complications. The combined procedures are said to be more effective as they have lower mean post-operative intraocular pressures rather than phacoemulsification alone, requiring fewer topical glaucoma drugs and fewer complications. The post-operative care has been well emphasized by Dr. Rita. I will not go into that again. And cycloplegics should be part of that for the first couple of weeks. The complications are many, but if we do a meticulous care, meticulous follow-up, they should be followed up frequently, and every time when we see them, we should see if there is a leakage or not. And hopefully we will be able to release the jam and give our patients good vision. Now, Dr. Ramanjeet's slides are there. Excuse me? Dr. Ramanjeet's slides. Dr. Ramanjeet had said that actually, because as it is in patients of angle closure glaucoma, there is sclerosis of the trabecular meshwork. Hence, performing a cataract surgery alone would not be able to change the scenario. And there are many studies. Actually, there are studies which lean towards phacoemulsification being advantageous, others which lean towards phacotrab being advantageous. But we need to remember that most of the studies were done in open angle. The angle closure studies have only been coming for the last for the last 5 years or so. More done in Asian populations. Indians do need to publish more of these things. There is a very nice article by Tham, which compares both in uncontrolled and controlled primary angle closure glaucoma, the role of phacotrab versus trab, and they found that that there is certain the IOPs are almost similar. It's just that there is more endothelial loss when we do a cataract surgery alone. And so they say that, and in RP Center they did a study where they followed up patients from over 3 years, and they found that after 3 years, the one parameter which the patients varied in the group of patients, whether they were POAG undergoing cataract, PACG undergoing cataract, patients of trabeculectomy undergoing cataract, the one thing which was found was that every cataract surgery led to a decrease in the endothelial cells. So we should, in conclusion, she would like to have said is that don't attempt to remove a cataract unless it is visually impairing. And then if it is visually impairing, go in for a phacotrab. So in short, that was those were her views. And I thank all the listeners for our instruction course. And if there are any questions, we will have them in a quick moment, because as it is, the next speakers are here. Thank you so much for being here.
We want to discuss whether somebody doesn't want glasses any time to achieve the full range of vision without glasses for any age of patients or persons. and to maintain the quality of vision as in would have in young persons of 20 years, so that we can improve the lifestyle. We have eminent speakers from all across. We have Dr. Sudhan Bharti from Delhi. He'll be talking to us for monovision by monofocal IOLs. Then we have Herbal Slav. He'll be talking on multifocal IOLs. Then we have Professor Mike Holzer. I hope he's here. Yeah, thank you very much for coming. He will be talking to us on influence of near addition in multifocal IOLs on functional outcomes. And it's my pleasure to introduce him to you with a brief biodata that he is at the University of Heidelberg, Germany. He is Associate Professor, Director of Refractive Surgery, Vice Chairman of the Department of Ophthalmology, Vice Chairman of the International Vision Correction Research Center. He has research interest on refractive surgery, excimer femtosecond, keratoplasty, keratoconus, IOLs, implants, all kinds of IOLs, you can see that. And moreover, he has received several awards and given presentations and lectures at various international conferences, and now in Agra, India. He has a very big CV, but I'm sorry that I had to concise because of limitation of time. We have Hardik Shroff, he will be talking to us on accommodative IOLs. Then we have Dr. Rajiv Chaudhary. When he works, he will mix and match. Dr. Kulin Kothari, very eminent person from Mumbai, will be covering the panel discussion. And this is most important. I request speakers to stick to their timing so we can have some questions or some difficulties from the audience. And we would like to have interaction. There is one request. Please keep your mobile phones on the vibrator mode, and we don't have the evaluation form here, so that is out. So let's start. I invite Dr. Bharti for monofocal monovision, sir.
Friends, and at the outset I wish to thank Dr. Ashok Shroff, who has given me this opportunity to be with you and talk about the monovision with monofocals. And Agra is the place where I studied, spent the crucial and most important 8.5 years of my life, and did my MBBS and MS from here. So it's a very pleasant homecoming. Monovision is an optical trick to get around the problems of presbyopia, whether it is natural or pseudophakic, and one eye is made good for distance and the other eye for near, and there is definitely an element of neuroadaptation involved with the monovision. After 1 to 2 weeks, the brain learns to focus distant objects with the distant focused eye and near objects with the near focused eye. And the brain uses the monovision seamlessly without realizing which eye is being used for distance and which eye for near. So this is a very nice option in patients who have indications to be having this kind of possibility. Dominant eye is for distance and other eye is for near. That is the basic principle. And this gives the benefit of a wide range of vision. So when we're talking about monovision, it also gives a good vision for intermediate distance, and that's another pleasant aspect of the whole scenario. The advantages are it's cheap, so there is no special IOL required, and one can control the kind of IOL he is used to, because once you are used to, you have your own technique, no change in calculation of power. You don't require special training for centration, IOL power calculation, sitting where the IOL is sitting. Experience with your own surgeon's constant, and you are achieving the target power for years, so you know what we are talking about. When you want a distance good, then you will get a distance good. When you want a near good, then you get it. Whatever residual power you are wanting, you are getting that. Also, if there is a decentration, has no effect. No loss of a multifocal effect with the decentration of 0.3 mm. So this is another issue which is very, very significant, that you don't lose that. And there is, of course, like in a multifocal, there is metamorphopsia, so there is absolutely no metamorphopsia with this kind of possibility. No effect of capsular phimosis, where the lens gets decentered, up, down, left, right, whatever. And no effect of small error in power calculation. If you have a little bit of error in the power calculation, you still see good with both the eyes, because you've already explained the patient that the patient is going to see good for distance and near both, with both the eyes open. You're not, giving him an option that he can see one eye, good with one eye. The disadvantages is that 10 to 15% of people are not able to adapt to monovision, and there is loss of stereopsis. And if there is a possibility that the patient is not adapting to this situation, then you can correct with laser or IOL exchange. So there's this possibility that exists. Sorry, I think I opened the wrong file. Sorry for that. That I am going too fast, but then
Meanwhile, the Dr. Bharti is
you have to give me one more minute.
In fact, the idea of because this 1886 and 6 vision has been the goal. Everybody wants the no glasses. Even those who have been using for years together. So this is the idea of the course, that after cataract surgery, because cataract has now reached to be almost perfection, particularly in the senior hands. But there is a lot of debate going on about the selection of IOL. So this is the idea, where because we all as a practitioner we come across different sections. I mean, people from different sections in the society. They are celebrities, they are non-celebrities, they are from different profession. So this is at the end of the day, after the end of completion of course, we try to give you a clear-cut message that in which patient you should allocate which. And meanwhile, I would.
Dr. Shroff, I think you have to take another speaker. Because I have this presentation in my computer. Sorry for that.
Never mind. So, but you will lose 2 minutes already. You lost.
Yeah, I have lost 2 minutes.
So I request the next speaker, Dr. Abdul Salam, to go on to the monofocal, multifocal IOLs.
I think, meanwhile, when I go to the multifocal IOL, they want to have one eye perfect for distance, another eye just 1.5 so that he can read the SMSs and mobile. Or we want, what way we want to go?
Going home, used to drive, then accommodative IOLs are the best. If there is indication, or there is no contraindication, I would say. But accommodative IOLs are the best. Or otherwise you can go for monovision. Monofocal monovision. Sorry, even ophthalmologists, because they have heard a lot about glares and hellos from the patients. Now they will be the last person to go for the multifocal. At least I won't go for that.
Should we start?
Please. Sorry.
So, good afternoon, friends, and I'll be talking a little bit of basics of the multifocal IOLs. We know that the presbyopia is the complication of a cataract surgery. And all of us will love to have youthful, unabated optical quality of the vision after surgery. And not only we are looking at good quality of vision, near and distance, stillness, acuity, but at the same time we are also looking at a good modulation transfer function, that is a good contrast sensitivity, there should be no loss of a contrast, and it should be free from a photopic phenomena which we have even with the monofocal IOLs. So the options are multifocal IOLs and accommodative IOLs, which may be refractive and diffractive. So these were the refractive multifocal IOLs, and they had 5 progressive zones, and they gave a very good intermediate vision, but the photopic phenomena were so high that they are more or less now abundant. And another problem was they were pupil dependent, because for this zone to come into the play, pupil size has to be 3.5 millimeter. So if the pupil size, which most of the elderly patients have, because the Meos pupil and a brown iris, many of them do not have that much of pupil size. So in Indian situations, because of the pupil size, though I implanted some of these lenses after doing a sphincterotomy, but were not very ideal and had a lot of problems to the patients and needed many a times explant. Now, this was this is the lens which we are implanting. I don't think we need to go into the details of implantation of the technique, because implantation is the same. But these lenses were 50% light was distributed for distance, 13% for the intermediate, and 37% for the near. And this was the addition at the spectral plane. And patient need to be kept slightly on the hypermetropic side to avoid photopic phenomena. Now the refractive multifocal are far superior because they give more clear-cut and well-defined images. What is the diffraction is, we have known that whenever the light travels from one media to another optical density media, it bends. Diffraction is a different phenomenon where the light bends even when there is no change in the media because of the S. So this S which is created over here like Fresnel prism causes this light to split into two. And how much light you can actually decide whether how much light should go to this side and how much should go to this side, at what distance it should go, and how many rings are there. So depending upon the number of rings, height and angle of these edges, you can divide the distribution of the light. That means you have got a 2.5 at, 3.5, 4, intermediate, and if the gap between them is more, then more light will be going for distance and less will be coming for near. If you compact them, then more light distribution will be more equal. So you can actually decide the light going for the distance, for the near, and at what level of focus you want. And these were the basic Ormesia company Technis multifocal lenses. You can see the multiple rings over here, and it gave a very sharp, very good focus for near. They had a very good vision for near, and there was equal distribution for near and distance. And then, because probably the requirement, always the patient has more requirement for distance than for near. So this came the active twin lens. All these lenses were used as our thesis. I am not going to the details of their data, just I am introducing the subject. So these diffractive foldable IOL had one lens had 30% for distance, another had a 70% for distance. So the advantage was, now in a dominant eye you put in a distant dominant lens. So if you see that these plates, this is not so focused, this is better focused. And when you see the next plate, this is focused and this is not so focused. And the patient sees with both the eyes, then near and distance both are focused. So this is like a monofocal lenses with the multifocality, one lens more dominant for distance, another more dominant for near. So this all plays are possible. Even one lens, now we are having a trifocal lens which can divide the lines. So the over the period of time, what problem we were facing of the glare and halos and the loss of a contrast sensitivity. So the restored lens came, what we call as apodization. That means these rings were made less in height so that they are used more for distribution of light for distance. And after 3.4, 3.5, this is all for distance. That means in a night when patient is getting down the stairs, people is widely dilated, he gets more vision for distance. And even in this case, now they have come out with a 2.5 diopter. That means the patient and the number of rings are gone down, so that only it can serve the purpose of reading your SMSs, which is now becoming very important part. So it gives you around say 1.5 diopter of addition, and very few rings, so much less halos, more distant dominant, and it still can serve the purpose of seeing your mobile phone and reading SMSs. So the problem of these was these refractive multifocal, this is the near point of focus and this is the distance point of focus. So when the light crosses over, you will see that if this is a sharply focused, this is a defocused light over here. So whenever, now there are two foci which are there, now what happens? why we lose the contrast. Now, if you are seeing this letter, if you see a dot, it will have multiple rings because of that. So when you are seeing this letter E written on a white background, there will be, between a white and a black, there will be grey shade. Because the light which was focused before will superimpose a bigger image on top of this. So some of the patients who are very sharp, very intelligent will come and tell you that they are seeing the shadow over there. So this is where he loses the contrast. And whenever he is seeing a bright object against a dark background, so then this bright object will also have a many bright rings around it. So this is where he gets halogen glare. So these multifocal lenses, on the one hand, were giving you the choice of reading without glasses. On the other hand, they were decreasing the contrast and increasing the glare to the patient. So the patient, so whether these multifocal lenses to be used or not, how they perform in a clinical trial, this will be covered by the next speaker. But if you see what are the patient's factor for selecting those patients, whether patient can comfortably afford it. I mean, if 2,000 piece, don't make any difference to him, don't force him. What is the behavior of the patient? Psychologically, whether he can accept things. If it's very finicky type of patient, you can't use them. If it is a cards and club type of a person or a lady, she'll be more than happy if she can go to the kiddie party, play clubs and see the things. If he has got no driver, if he has to drive himself, probably he will be unhappy. And then most important is what is the eye condition. Whether patient has got astigmatism. So because these lenses were not suitable if the cylindrical power is more than 1 and definitely if it is more than 1.5. These lenses are not suitable if the angle alpha is more. I think previous speaker was talking about decentration. Even if there is no decentration, if the angle alpha is more, patient is not going to happy. If it is not well onto the visual axis. And same way if there are higher order aberrations and the eye has to be pathology free. So all these prerequisites are there before you can use these multifocal ions. And then the surgeon's factor is very, very important. He should have a setup where he can measure the angle alpha. We have removed some of the lenses, and once we examined them on an eye trace, we found that the angle alpha was very large. Biometry has to be very accurate. You cannot rely upon an ultrasound biometry. You need to have a lens SR or IOL master. This video is simultaneously I am showing how to explant the lens. Counseling, either you need to do the counseling of the patient or you need to have a counselor who can convince the patient. You need to devote more time with the patient pre-op and post-op, and you should know how to explant the lens if patient is troubling you or if patient is in trouble. So this is a very simple technique. Just hold the lens over here. Any forceps will do. You don't have to have any special seizure, any tooth forceps. Can hold the lens over here. One loop is out, another loop is in. Any tooth forceps will do the job. Go inside the incision, hold it, cut with any seizure. Any corneal seizure, conjunctival seizure, Vanna seizure, you just want to have one straight cut going up to the center. Once this cut has gone up to the center, one of this will go underneath the corneal lip. The wall you have created, it goes underneath. One comes out of the wound. One is underneath this, one is in the incision. And then just dial it out, it comes out very comfortably from 3 mm incision, 3.2 mm incision without any problem. Now I am putting this one underneath the corneal lip, the wall which you have created, and then just dial it out. You can cut off this loop if you want beforehand, or it will also come out. So these lenses come out very easily, very simple. Do not take more than 2 minutes to remove these lenses. And my only advice will be that do not be defensive if patient is troubling you. Anytime any patient tells me, I always promise them, if you have got any problem, I will exchange your lens into monofocal free of cost whenever you want. And I have removed these lenses even 8 years old, 5 years old, 7 years old. They come out very easily. So do not be afraid of removing these lenses if patient is troubling you. And this is the headquarter building which is coming up in Delhi. Is really now beautiful in shape. If you have a time while going back, look into it. And this was the book which is long awaited. Now it's available. I written 12 years back and a lot of requests for the re-edition. And these are of course the chemistries you must have seen. Thank you very much for your kind attention.
Request Dr. Professor Mike Holzer.
In multifocal lenses. You have heard already about the different multifocal lens designs. These are the financial disclosures for the last 2 years for our research center. And we know everybody of us will be affected by presbyopia. The need for reading glasses is there. And we also know that the patients are very demanding nowadays, and they really need a good near reading ability. The different working principles I think we can skip because you heard that just in the previous talks or previous talk. I would just add one more lens, that's the segmental multifocal lens called the Lentis M+, where there is a near edge in the lower part of the lens, and this one also works very well. All of these lenses are, or most of those lenses are also combinable with toric or astigmatism correction. You have seen these photographs, so I will go to this slide where we ask ourselves what is really near, and that is something that we need to discuss with our patient, because for one, near would be at 30 centimeters, for the other one it would be working at the notebook screen, which is more than 60 centimeters away. So we really need to discuss that with the patient, what the specific needs are that he has. We have looked at one specific lens, that's the Rayner M-Flex, because this lens is available with two different near edges, one with a +3 and the other lens with a +4. The lens is made of hydrophilic acrylic, and the lens is delivered with 0.5 diopters increments. We have looked at these lenses in 104 eyes, and we divided the patients into 3 different groups. Group 1 received a +3 near edge bilaterally, Group 2 +4 bilaterally, and Group 3 was a mix and match approach with a +3 in the dominant and +4 in the non-dominant eye. And we looked at different outcome measurements, ETDRS charts, focus curves, to see if there's really a benefit with the mix and match approach or a benefit with the +4 diopter lens. These are the outcomes, and you see here the 3 different groups, group 1, 2, 3. And first of all, the uncorrected distance visual acuity is not different at all between the 3 different groups, as well as the spherical equivalent that we achieved. If we look at the near visual acuity, again, there is no statistical difference between the 3 different groups, which is very interesting. And if we look at the distance-corrected near visual acuity, and this distance-corrected near visual acuity is the best term to really look at the outcome of such a lens, how the lens is doing, because you correct totally for the distance. If we look at the numbers, we're at 0.1 in the median, which is equal to 2025 near visual acuity, and no difference between different groups at all. The near edge that was necessary to achieve the best near visual acuity was somewhere between 0 and 0.25, so we can say almost nothing. If we look at the defocus curves, however, we see a difference between the +3 and +4, especially if you look at the intermediate range. With the +4, we have a much further decline in comparison to the +3, which stops somewhere between 0.3 and 0.4 log bar. At the same time, the near visual acuity, the best near visual acuity, is not really better for the +4. It's just closer to the eye. And then if we look also bilaterally, and if we include also group 3, which is the mix and match approach, again, group 1 would be the +3, group 2 would be the +4 with the further decline in intermediate visual acuity. And the mix and match is pretty similar to the +3, so not really a better outcome, but similar to the +3. And if you compare to the unilateral, of course, with the bilateral defocus curve, you have slightly better values if you use such lenses bilaterally. Then we looked at the target versus achieved. Here we were pretty good. We had a slight tendency to a little bit of hyperopic shift. Therefore, the data was sent to Professor Heigis, who adjusted the A constant for this lens. We also did a patient questionnaire where we asked, when do you really need glasses? And if they need glasses, then we can say that the intermediate range is not really the best. For distance, they were all of them mainly without glasses, and for reading, just some of them needed help with reading glasses. Regarding glare and halo perception, yes, there is halo. About half of the patients answered yes, they do realize halos. Glare perception was, in the majority of the cases, minimally graded. Patient outcome overall very satisfied and satisfied. For most of the patients, there was just one who was dissatisfied, but altogether the outcome is very well. We also looked at contrast sensitivity. Here we can say that we are, with this lens, with the median, pretty similar to other studies that have been published on the M+, as well as the Restore lens. If you compare the values, they are pretty similar. We also looked at stray light measurements. There's a device, Sequent from Oculus, where you can measure really stray light. And for example, these crosses here, they stand for a cataract eye, and the higher the value, the more stray light they have. And if we look at the median of those patients implanted with this multifocal lens, they are just where the general population should be, so stray light was not really an issue. We also looked at defocus curves with other lenses, other multifocal lenses that we use at our department here, the M+ with this near segment. This is a kind of refractive principle. We have quite good near visual acuity, and if we look at the intermediate range, we have the lowest at 0.3 logMAR, so a quite acceptable intermediate visual acuity for this lens. Then here, in contrast, the diffractive +4, that would be the Technis lens, and here you see that the near visual acuity is slightly better. However, the intermediate range drops below the 0.3 line. We are here at 0.4, and also the +4 is shifting the really near focus closer to the eye. If we look into the literature, also other studies have been published on this topic here, a study comparing the Restore +3 comparing to +4. Their outcomes were, just to summarize, in conclusion, they didn't find a significant difference regarding the near and distance visual acuity comparing +3 and +4. However, intermediate was significantly better for the +3, and the focus curve showed that the intermediate distance was at 87 centimeters for the +4 and at 65 centimeters for the +3. So this indicates it's really important when we decide for a lens that we ask the patients pre-operatively where their favorites are. Another study from Meester et al., they also compared +3 with +4, and they found that the intermediate visual acuity was significantly better for the +3, and the binocular results, of course, were better than the monocular ones. And here, finally, a study from Alfonso from Spain, who looked at several lenses that are on the market, +3, +4, +3 3/4, and what he found is that the defocus curve was really the best for the +3, and that the +4 did not really have a better near visual acuity. So we can summarize. We have common findings that there is no significant difference between the +3 and +4 regarding distance and near visual acuity. Binocular results, of course, are better than monocular outcomes, therefore bilateral surgery is important. And as we all know, emmetropia is essential, so we need to correct remaining refractive errors, for example, with the excimer laser. Differences regarding reading distance. With the +3, we are at about 40 centimeters. With +4, we are at 33 centimeters. Advantages of the +3 near edge: we have a better defocus curve, better intermediate visual acuity, spectacle independence, as well as patient satisfaction was better. And with the mix and match approach, to also look at that, finally, we did not find a further advantage regarding the intermediate distance, and also no significant near visual acuity gain if we did this mix and match approach. So our standard multifocal approach at the moment is a +3 near edge, and putting that lens in both eyes, and of course looking at the astigmatism to make sure that there's no remaining astigmatism, no remaining refractive error. Thank you very much for your kind attention.
Thank you, Dr. Further, I will request Dr. Bharti to go on the monofocal monovision.
To take the rest of the talk. Thanks. Thank you very much. And couple of slides I have already spoken about, so it's a kind of, I talked about this, and blended or limited monovision, as I talked, was for the intermediate vision. And this I already spoke, that 1 to 2 weeks, it is the brain training time, and it has benefit of. And this is the pictorial representation where one eye is corrected surgically to allow clear distant vision, whether it is with laser or with IOL, and the other eye is, it's talking about refractive, whether if it is a myope, it is not treated, but when I am talking about monofocal IOL, then the treated eye is for distance. And monovision for presbyopia is clear vision, one eye for distance and one eye for near. This is again a pictorial. And traditional, this is the important thing. Traditional monovision aims about 2 diopter of myopia defocus in the myopic eye or the eye corrected for near. And there is a suggestion by Professor Barrett that 1.25 defocus is better so that there is no problem of dissociation between 2 eyes, since this is a very small difference. And contrast sensitivity and stereoacuity is also preserved in all these cases. So this is slightly better than having a complete monovision where one eye is absolutely fantastic for near. But this is also sometimes unacceptable, and it is not giving a very nice near vision. I have already talked about the advantages of monovision. The decentration has no effect, and no metamorphopsia, halos, ghost images or glare, and no effect of phimosis or small error in refractive error. Also, the top-up glasses can be used for better vision when prolonged reading is required or driving in poor light, right, like raining. So this is another factor which can be used when you have done a monovision, but the patient is ready to use glasses for certain circumstances, and that's basically a counseling. And I told you about the disadvantages and that it can be corrected. If the patient doesn't accept, we can correct it with laser or ion exchange. Dr. Margaret MacDonald said that some people are strongly left-right dominant and thus have trouble adjusting, because in those cases it is sometimes very difficult to make sure that we are treating the dominant eye for distance. And with his colleagues in the process of developing a neurocognitive quantitative test to look for that issue. And this is still in the process. Considerations against monovision, where we do not counsel the patient for monovision, is not for people requiring better than average vision and binocularity like pilots, and it is not for people wanting rapid improvement. Since it may take some at least few weeks, but sometimes up to 2 months. And night driving may also be difficult due to decreased depth perception, because of the monovision doesn't give a very fantastic stereoacuity. Patient counseling is the fundamental, it has to be very good. The success entirely depends on patient's understanding and expectations of them. And patient has to be informed about the risks, limitations and side effects which he understands and accepts. And it may not entirely eliminate the need for corrective lenses, which may be needed, of course, for very fine and detailed activities for distance and near both. So this is the complete monovision, and I suggest that one should try this, because I have tried it in a few patients.